In a previous video, we reviewed the most basic forms of mechanical ventilation, pressure control ventilation and controlled mandatory ventilation. We also looked at the basic settings, including fraction of inspired oxygen, respiratory rate, IE ratios, and either tidal volume or inspiratory pressure. Control modes of ventilation are easy to understand and are very reliable. However, as the patient wakes and effort to breathe returns, these efforts may be unrewarded by the ventilator. This can be very distressing. For this reason, modern ventilators have the ability to recognise when a patient attempts to breathe and to support that effort. In this podcast, we will review these modes of ventilation, including assist control, intermittent mandatory ventilation, and pressure support ventilation. For all these modes to be effective, the ventilator must be able to identify when the patient is breathing. This is known as triggering. There are two main methods that the ventilator uses to detect the patient's efforts to breathe, known as flow trigger and pressure trigger. Ventilators were first developed to detect changes in circuit pressure resulting from the patient's effort to breathe in. As the patient begins to inspire against a closed circuit, the ventilator circuit pressure drops. This is recognised by the ventilator, which responds by opening the inspiratory valves, known as demand valves, allowing gas to flow in a manner determined by the ventilator settings, as discussed later. This mechanism is very neatly demonstrated here. As I generate a negative pressure with the test balloon, the ventilator responds by providing a positive pressure breath. Flow triggering is an alternative strategy employed by most modern ventilators. In older ventilators, between delivered breaths, all gas movement within the circuit ceases. In newer ventilators, a continuous flow of gas continues around the circuit, bypassing the patient as shown here. This flow is known as bias flow and occurs at a constant rate, for example 3 litres per minute, and is monitored by an expiratory flow sensor. When the patient attempts to breathe in, the flow of gas reaching the expiratory flow sensor falls. This triggers the ventilator to provide inspiratory support. The major advantage of flow triggering over pressure triggering is that it takes considerably less effort to reach threshold for activation of the ventilator. This may be very important in long-term ICU patients who are very weak. Pressure triggering has also been criticised for a delay between the activation of the respiratory muscles and the delivery of a breath, and it has been argued that this delay is minimised using flow triggering. In reality, however, in modern systems, there is little difference between pressure and flow triggers. The sensitivity of the trigger defines how easy it is for the patient to initiate a breath. The ventilator is easier to trigger if the pressure or flow required to activate the ventilator is low, and harder if they are high. Common initial settings are shown here. If the sensitivity is set too low, weaker patients may find it difficult to trigger the ventilator, resulting in significant distress and failure to wean. An example of a pressure waveform from a ventilator in such a patient is shown here. Pressure dips are clearly visible, but none are sufficient for the ventilator to activate. In such cases, it may be beneficial to reduce the sensitivity of the ventilator, making it easier for the patient to start a breath. Conversely, however, setting the sensitivity too high will potentially result in the ventilator trigger being activated by stimuli other than a patient attempting to breathe. This is known as auto-cycling. Examples can include condensate sloshing in the ventilator tubing, cardiac oscillations, and patient movements. When this occurs, the ventilator may inappropriately be triggered, possibly resulting in overventilation and patient distress. In these cases, the sensitivity of the ventilator will need to be decreased. It is worth noting that increasing the sensitivity involves decreasing the flow or pressure required to trigger the ventilator. For example, the ventilator is more sensitive to the patient's needs if the flow trigger is reduced from 2 litres per minute to say 1.5 litres per minute. That is, the patient only needs to divert 1.5 litres per minute of flow away from the bias flow to trigger the ventilator. In Assist Control Ventilation Mode, or ACV, the ventilator is set in the exact same manner as controlled mode. However, in addition to the set frequency, a patient effort to breathe will be rewarded with the delivery of a breath identical to that of a mandatory breath. Because this breath is controlled, the patient has no capacity to influence the volume delivered. An example is shown here. Note that the shape of the mandatory breaths and the patient-controlled breaths appear the same. The patient-triggered breath can be identified from the negative pressure deflection immediately prior to the breath. ACV was designed partly to allow patients some control over their own ventilation. However, there are a number of reasons why ACV is not as well tolerated as could be expected. In this mode, the patient can increase their ventilation by increasing their respiratory rate. However, the volume cannot be regulated by the patient as the tidal volume is fixed. This is very important as the feeling of over or under ventilation has a considerable impact on patient comfort. Other modes, discussed soon, allow better control of the tidal volume. Additionally, because the inspiratory time is fixed for both mandatory and spontaneous breaths, the proportion of the respiratory cycle spent in inspiration increases significantly as the respiratory rate increases. This can be distressing for the patient and can lead to breath stacking and raised intrathoracic pressures with hemodynamic consequences. Theoretically, the ventilator assumes that the raised respiratory rate always implies that the patient needs further respiratory support. However, for some patients this is not true. In patients with significant tachypnea due to non-pulmonary reasons such as pain, anxiety or delirium, the additional ventilation may result in overventilation, distress and respiratory alkalosis. Finally, even though the ventilator can potentially reduce the work required for the respiratory muscles, available evidence suggests that once activated, the respiratory muscles continue to contract maximally through most, if not all, of the assisted breath. Despite these limitations, ACV has been widely adopted, particularly in the early phase of illness when patients have very limited respiratory effort. Basic settings for ACV are shown here.
Intermittent mandatory ventilation was designed almost 40 years ago to assist with weaning from controlled mandatory ventilation. In theory, IMV allows the clinician to set a mandatory backup ventilation strategy while allowing the patient to initiate their own breathing efforts. As the patient becomes stronger and respiratory drive improves, the mandatory strategy can be weaned further until ventilatory support is negligible.
Synchronised IMV allows for the mandatory breaths to be timed to the patient's initiated breath. This is thought to improve patient comfort. To do so, the ventilator pauses briefly, a period known as the assist window or synchronised period. The ventilator pauses to see if the patient will trigger the ventilator. If it does, the machine delivers a full mandatory breath synchronised with the patient's effort, as shown in the diagram. If the patient does not trigger the ventilator,
the machine goes ahead and delivers an untriggered mandatory breath. In this way, the ventilator ensures that a mandatory minimum quantity of ventilation is delivered. Mandatory breaths may be either pressure regulated or volume regulated in nature. Like ACV, the patient-triggered breaths can be identified by the negative pressure dip immediately prior to the breath. In addition to the synchronized intermittent mandatory breaths, additional efforts by the patient will be supported by the ventilator. Unlike ACV, rather than delivering additional controlled breaths, the ventilator provides pressure to the circuit to assist inspiration. This is known as pressure support ventilation and is discussed further in a moment. In practice, SIMV may resemble controlled mandatory ventilation when the patient's effort is absent, able to fully ventilate the patient. The advantages of SIMV are that it provides a safe background ventilation strategy that is synchronised to the patient's effort, improving comfort. It also provides ventilation support for patients who trigger the ventilator more often than the background mandatory rate, and the patient is able to partly control the volumes achieved. Therefore, respiratory alkalosis, hyperinflation, and patient discomfort are far less problematic than with ACV. SIMV has become so popular due to its versatility and safety that it is the primary ventilation mode in many countries and is the default mode on most ventilators. SIMV was initially developed as a weaning tool, the theory being that as the patient's strength and effort returned, the amount of background ventilation could be reduced. Unfortunately, in the weaning studies done to date, SIMV has been found to be inferior to pressure support ventilation and T-piece trials as a method for facilitating weaning. This will be discussed further in a later vodcast. In practice, the settings for SIMV depend on the patient's status. Initially, the ventilator can be largely set to reflect the CMV setup described in previous vodcasts, with a set tidal volume or inspiratory pressure, set respiratory rate, PEEP, and IE ratio. If the patient is not spontaneously ventilating, the delivered ventilation will be very similar to controlled mandatory ventilation. If the patient is breathing spontaneously, the trigger setting must be considered. Default settings listed previously in this vodcast are appropriate in most cases. If the patient is breathing above the mandatory rate, then settings for the supported breaths must also be considered. This is done the same as in pressure support modes to be discussed next. Usually, the pressure support is set to ensure that the appropriate tidal volumes are achieved comfortably for the patient. As the patient improves, the objectives of the ventilation strategy may shift to improving patient strength and weaning from the ventilator. In this situation, the mandatory ventilation settings can be reduced, usually the rate, allowing the patient to initiate more breaths. The pressure support applied for the additional spontaneous breaths may also be reduced, requiring the patient to perform more respiratory work, gradually improving strength, until all work of breathing can be done by the patient. Weaning from ventilation is a complicated subject that will be further addressed in a later vodcast. In pressure support modes, the patient initiates their own breathing efforts, and in response the ventilator generates a positive pressure that is applied to the circuit to assist them with inflation. In theory, this reduces the patient's work of breathing. The difference between pressure control and pressure support ventilation is that in PCV, the application of the breath is controlled in that the inspiratory time is fixed. In PSV, the patient controls cycling into expiration. The tidal volume thus may vary considerably from breath to breath, depending on the patient's effort and other characteristics. Additionally, if the patient breathes in, this creates a negative intrapleural pressure that adds to the applied positive pressure, generating larger tidal volumes. The harder the patient breathes in, the larger the tidal volume will be. Given these facts, the patient is able to partly control the volume of these breaths, better matching their needs. This also applies to the pressure-supported breaths in SIMV mode. In pressure support ventilation, the ventilator must also be triggered to cycle into expiration. The ventilator recognises that the patient wishes to exhale when the inspiratory flow falls below a certain threshold value, usually defined as a percentage of peak inspiratory flow, for example less than 25%, or an absolute flow rate, such as less than 5 litres a minute. This threshold value can be modified, though this is beyond the scope of this vodcast. Important settings for pressure support ventilation include the trigger as previously discussed, the degree of pressure support applied, the profile of the breath, and the trigger for cycling into expiration. The default settings for inspiratory trigger, expiratory trigger, and profile are usually appropriate as a starting point for most patients. Settings in specific circumstances will be described separately. The volume of gas inspired is determined by the transalveolar pressure. This is a combination of the positive pressure applied by the ventilator and the negative intrapleural pressure generated by the patient. Increasing the applied pressure will therefore allow the patient to reduce their work of breathing without sacrificing tidal volume. In fact, increasing inspiratory pressure may not alter tidal volume at all if the patient reduces their effort proportionately. As a general rule, pressure should be set to enable the patient to comfortably achieve tidal volumes of 5 to 7 mils per kilo of ideal body weight. In practice, this usually ranges from between 5 to as much as 20 centimetres of water. If pressure support is then reduced, to maintain the same tidal volume, the patient will be required to exert more effort. Depending on clinical circumstances, this may or may not be desirable and is best measured by observing the patient for signs of respiratory effort and distress. Failing to provide sufficient inspiratory pressure generally results in tachypnea in order for the patient to maintain the desired minute ventilation as tidal volumes will fall. Pressure support ventilation can be weaned as the patient's respiratory effort and strength return, allowing a smooth transition to unassisted breathing. Because the endotracheal tube and circuit impose an increase in the resistance to breathing, pressure support is never reduced to zero. In many cases, the exact value required to precisely match this increased resistance is not commonly known. It is widely assumed to be between 5 and 10 centimetres of water. Some ventilators, however, have a setting known as automated tube compensation or ATC. When this setting is activated, the ventilator calculates, based on the tube size and circuit type, the exact pressure required to overcome this resistance. In this situation, the inspiratory pressure can be set to indicating that no additional inspiratory support is being given to the patient other than that required to overcome the endotracheal tube and circuit resistance. Because ventilation in pressure support is entirely dependent on the patient initiating each breath, there is a theoretical risk of the patient becoming completely apneic if they fail to trigger the ventilator. Pressure support modes therefore have an apnea mode, a safety feature that kicks in for just such a circumstance. The required settings for this feature should be reviewed, but for most patients the default settings are adequate.
The disadvantages of pressure support ventilation include the variability of tidal volumes and the potential to overventilate the patient.
Also,
Fail to inappropriately titrate pressure can impose a higher work of breathing than necessary and increase patient distress. In this vodcast, we have reviewed how the ventilator responds to the patient who attempts to initiate their own breaths. Through the modes assist control ventilation, SIMV and pressure support, the ventilator applies varying degrees of support to facilitate ventilation.